I think we're due to time, and it's still some of the delegates are still have their lunch, but I think we need to start so that we stay in time. My name is William Smoker. I'm from MDH, Management Disease for Health. I'll be your moderator of today's session. And our today's session is all about HIV drug resistance, as you can see in our brochures. And with us today, we have a very strong panelist to be able to take us through the HIV drug resistance. And yes, thanks. So as I tried to say from the beginning, this is HIV drug resistance forum, which will be taken today, and we are trying to look towards the HIV drug resistance landscape, of which we'll be talking about the findings from the Programmatic, the surveillance, as well as the survey, part of the monitoring of the HIV drug resistance. And as part of the, just to give overview of what we are looking forward to. So on overview, we all know about the threats we have when it comes to HIV drug resistance, on effectiveness, on ART, as well as HIV epidemic control. That's our big picture at the end of the day. Or 2030, we expect to have HIV epidemic under control. So this is one of the crucial areas we think we need to talk about and be able to express what we found in part of the surveillance, which is the key purpose to the monitoring of HIV drug resistance. So we have the HIV drug surveillance, HIV drug resistance surveillance since 2023, which was focused among the unsuppressed clients with on the viral loads, and those who are resistant to Dolutegravir, which is one of the main component drug we have been using so far. So also we'll go further to see part of the clinical surveillance when it comes to HIV drug resistance, which is through the GRT, the GAT for adults and failing second line of ART. Testing from the part of the clinical, and also knowing more from the cadre. This is a cyclic HIV drug resistance surveillance, which has been also conducted in Tanzania. So as part of the forum, what we're expecting for all of us here is to have both from the government and non-government stakeholders, so that we all come together and discuss about drug resistance. And for the present is the findings from the GAT and the cadre and the Tanzania survey, Tanzania Health Impact Survey, which are some of the findings which you are going to see in these presentations. We would like to know of it, the risky factors, as well as management when it comes to the policy and the guidelines. So without further ado, I'll try to take you to our presenters. Part of our panelists are the first presenters, who is going to introduce us on HIV to drug resistance among the HIV. Can you get the next? So we have Professor Doreen Kamori, who will take us part of the general introduction to HIV drug resistance. Professor Doreen is an associate professor at MUHARS, heads the molecular laboratory section, and serves as director of postgraduate studies at Muhimbili University, and also she holds a medical doctor as well as the PhD in science, medical science, majoring in HIV viral immunology. As far as she's an expert in HIV viral immunology, and leads the national HIV surveillance. So part of she's going to take us about the introduction to HIV, to HIV on drug resistance. So for that, let me welcome on board Dr. Professor Doreen Kamori. Please welcome on podium.
Okay, thank you very much, Dr. Mauka, for that wonderful introduction. Good afternoon, ladies and gentlemen. I wish to express that it's really my pleasure and I feel great privilege to give an introduction on HIV drug resistance during this session. As we all know, HIV drug resistance is a critical challenge that continuously threatens our ART program. So it's very important that we have this kind of platform to discuss and understand better the burdens, the patterns, and drivers of HIV drug resistance so that we become more informed to come up with strategic initiatives that will ensure a sustainable ART program in Tanzania. So to start with, I would like to discuss briefly on the epidemiological trend for HIV infection. So according to the most recent findings from the Tanzania HIV Impact Survey, we see that the prevalence of HIV infection has relatively decreased. It is estimated now to be 4.4%. And what we can also appreciate is the fact that the number of new infections has declined from over 80,000 new infections per year to at least 60,000 new infections per year. And what we can also observe from the, this survey is the fact that the HIV prevalence tends to vary by sex, whereby we see that women more infected compared to men. And we can also appreciate that there is a variation of HIV prevalence by regions, with some of the regions within the southern highland part of Tanzania having a high prevalence of HIV more than 9%. So as stakeholders in HIV care and treatment, I think we can all appreciate that there have been a remarkable increase in number of people living with HIV who are initiated to antiretroviral therapy. When you compare the global data, we can see that from 2000 to most recent 2024, there has been a 10-fold increase on numbers of people living with HIV who are on treatment. And this is a successful story, and is mainly attributed to the increase in access of ART use globally as well as in Tanzania. And we can all appreciate that this journey has been successful because we see that the numbers of people dying from AIDS-related death keeps on decreasing over the years. However, despite this success in ART use, we see that we are faced with challenge of HIV drug resistance. And so far, evidence shows that all available ART drug classes, they are susceptible to be resisted by the virus. Although it may tend to differ, some of the ART drugs may be more susceptible to be resisted compared to others due to various factors. So I just want to briefly introduce the ART treatment options in Tanzania so that we may better understand on HIV drug resistance. So basically, according to our national treatment guideline, we have 4 different classes of ART drugs. So we have the non-nucleoside reverse transcriptase inhibitors, and then we have the nucleoside reverse transcriptase inhibitors, and these are the backbone of our ART regimen. So these 2 agents, they both work by targeting the reverse transcriptase, but the mechanism of resistance tends to differ. And then we have the integrase transfer inhibitors, which were introduced in 2019. And of importance is the 2nd generation integrase inhibitors. In this case, is dolutegravir, which is the first-line regimen in our country, with the default first-line regimen being TLD. Then we have the protease inhibitors. The protease inhibitors, these are used as part of 2nd line, and some clinical indications could be used as 1st line. And normally they are given in combination with 2 NRTIs. But besides this, in resource-rich countries, we have other agents such as the fusion inhibitors, and we have the capsid inhibitors, where we have drugs such as lenacapavir, which has become very popular in recent years due to its ability to have a long-acting effect, and therefore it is being established that it's a very good candidate for HIV prevention. So what is HIV drug resistance in a simple language? So HIV drug resistance, by definition, is when there's some changes in the genetic structure of the virus leading to making the drug, ART drug, fail to function as expected, and therefore allowing the viruses to keep on mutating, and eventually we have a predominating population of mutated virus within the circulation. Then once this occurs, then what we have is the loss of the ability of HIV drugs to block HIV replication, which leads to increase in viral load, treatment failure, and high morbidity and mortality. In terms of classification, HIV drug resistance we usually classified it into 2 main categories or group. We have what is called acquired HIV drug resistance, which basically occurs in individuals who are on treatment. And this is caused by drug selection pressure, as we are going to see in the subsequent slide. And then the other category is the pre-treatment HIV drug resistance that can either be transmitted. We have an HIV-infected individual with with viruses who have drug resistance mutation transmitting to an infected individual, but also it can occur in the situations whereby one had previous exposures of ART treatment, such as PrEP and others. So next now let us talk on how do these mutations actually occur. What are the drivers of these mutations? So here basically we have 2 key mechanisms. We have the inherent virus properties. So the HIV virus, naturally it has high replication capacity or rate. And due to this feature, accompanied with the lack of what we call reverse transcriptase proofreading function, it leads to make the virus mutate very rapidly during the process of replication. And some of these mutations that result may cause HIV drug resistance. But the other mechanism is ART drug selection pressure, which normally this is, can be influenced by several factors, including treatment interruption, subtherapeutic levels, and monotherapy. So in the presence of this, the drug tends to select and favor the mutated virus within the host or HIV-infected individual. So now let us go to the specific drug class resistance. So we have the NRTI, which basically it has 2 kind of mechanisms, but all of these involves mutations that occurs within the RT enzyme. So one, some of these mutations, they tend to affect the rate of the binding and incorporation of the nucleotides during viral replication. And here we have common mutations that are selected by tenofovir, such as K65R, that are reported within the Tanzanian population, but as well as globally. But the second mechanism is mutations that tends to increase excision of the NRTIs, and this is normally mediated by ATP. And here we have very unique kind of drug resistance mutations, commonly abbreviated as TAMS, which stands for thymidine analog mutations. And here we have basically 2 types of these kind of mutations, and we have several examples of mutations that occurs and causing this kind of effect. This occurs in several codon positions as indicated. For the NNRTI drug resistance, again, here we have mutations that tends to occur in the hydrophobic pocket of the enzyme, and this also tends to affect the rate of NNRTIs to bind with enzymes. And we have common mutations such as K103N that is normally selected by first generation NRTIs such as efavirenz and nevirapine. And this is common in our setting as well as elsewhere. And of course, several other mutations as indicated. For the protease inhibitors, also we have mutations that occurs in the active binding site of the enzyme, and they tend to prohibit binding of the protease inhibitors. We basically have two types of these mutations. We have major protease inhibitors, drug resistance mutation, and minor. And there are some of the examples, which includes mutation at codon position 82. This is very common in our setting as well as elsewhere. For the integrase inhibitors, also the mutations that occurs, they tend to occur in the active site of the integrase enzyme, affecting the binding ability of the drug to the enzyme. And we basically have two types of the drug resistance mutations. We have the major and accessory drug resistance mutation, which with the accessory themselves, they do not reduce the drug efficacy. Then we have a couple of examples of these HIV drug resistance mutations and INST, but some of the common ones include those located at position 118. This has been very common in our in our Tanzanian setting at codon 138 and codon position 263. These are some of the predominating mutations that have been seen in our Tanzanian populations and elsewhere. So basically, these are the key mechanisms and common circulating drug resistance mutations that have been reported in our population and elsewhere. So the next question is, how relevant are these drug resistance mutations? Why do we talk about these things? So one is the fact that they have a negative impact in people living with HIV. Because with the presence of drug resistance mutation that affect drug efficacy, subsequently leads to treatment failure, and in a situation whereby individuals have multiple drug resistance mutation, it tends to limit treatment options to these individuals and therefore subsequently leading to AIDS progression. But at a public health level perspective, we also see that the continuous accumulation of these HIV drug resistance mutation, they tend to lead to transmission of resistance into the uninfected individuals, which subsequently leads to the threat of ART sustainability. So what do we need to do? So it's very important that we come up with strategic initiatives that aim to at least slow the progress or prevent HIV drug resistance. And my colleagues who will be doing the next presentation will be talking into details on how some of these strategic initiatives have been implemented in the country. But just to highlight the few, we have a couple of them, such as improve adherence support, because suboptimal adherence has been shown to be one of the main driving force for HIV drug resistance in most settings, especially in sub-Saharan Africa. And then we have issues of strengthening monitoring of treatment outcome, monitoring early warning indicators and others. And then last but not least is scaling up HIV drug resistance testing. So while implementing this, we believe that we'll be able to prevent or control HIV drug resistance. And then that's it. Thank you very much.
Thanks, Professor Kamori, for that presentation. Please, can you give another round of applause? Thank you. So the next presenter, who is going to take us through the drug resistance part of the, can you get the next one? Yes, so we're going to have Frank, who's going to take us through the findings from the cadre, which is a psycho-acquired drug resistance patient monitoring in Tanzania, which was done. And just for part of introduction, Dr. Frank is a surveillance manager at Management and Development for Health, MDH. He's the medical doctor, and he holds the PhD he holds a PhD, and he has also masters in virology with more than 10 years experience in research and on infectious diseases, vaccine and immunology. He's responsible for strengthening disease surveillance, designing and up-to-dating protocols for conducting surveys and working with the stakeholders to improve the surveillance system in Tanzania. So with much pleasure, I would like to welcome Dr. Frank to the podium to take us through the findings from the surveillance which is ongoing on drug resistance. Karibu, Dr. Frank.
Good afternoon, everyone. Okay. So, on behalf of my colleague, Dr. Thomas John from CDC, I will be presenting our findings. The findings from the first laboratory-based surveillance of HIV drug resistance in Tanzania. So this is called cyclical acquired HIV drug resistance surveillance. So we call it cyclical because it is conducted in cycles. It is conducted annually. So each year we have one cycle of surveillance. And so far, we've already conducted 3 cycles of surveillance. So from 2023, 2024, and 2025. So today, I'll be sharing with you the results from the first round of 2023. So, as you're all aware, that currently, dolutegravir-based regimens are the cornerstone of HIV treatment in sub-Saharan Africa. And in Tanzania, nearly all patients are on DTG-based treatment. So although DTG is a very high genetic barrier to resistance, it means it is less likely to be affected by resistance mutations. When the virus develops resistance mutation, it is less likely to be affected. But what we have seen from clinical practice, that there is emergence of resistance against the DTG, our drug of choice in treatment of HIV infections. And so far, resistance ranges from very low level, from 4% to nearly 20%, and it's high among individuals who have a long history of being on antiretroviral therapy. So because of this emerging resistance, WHO recommends that we keep monitoring the performance of DTG among people living with HIV. So we should conduct routine surveillance, routine HIV drug resistance surveillance to monitor emergence of resistance against DTG. And this surveillance can be performed either clinically or it can be laboratory-based. So it can be conducted at the clinic where you meet patients and you take samples. But the clinic-based model is usually more expensive. So we decided to conduct the laboratory-based survey. And this is a new approach which is being conducted in 17 countries globally. So 14 of them are in Africa, and Tanzania is one of them. And it is also a cost-effective approach because it is utilizing the existing laboratory infrastructure. So there's nothing new. We had nothing new, so we are using the same laboratory-based laboratory information system, the sample referral system. So it is much more cost-effective compared to the clinic-based laboratory surveillance. So in Tanzania, we have conducted 3 surveillance cycles, country cycles. The first one in 2023, and the second one, which was completed last year in 2024, and currently we are testing the samples. And we have recently just concluded the third round. So our primary objective in CADRI is actually to estimate the proportion and describe the patterns of acquired HIV drug among individuals who are not suppressed despite being on DTG-based regimen for more than 9 months. Okay. So by acquired drug resistance, we mean these are individuals who are on treatment. And DTG is very effective, but despite being on DTG for at least 9 months, they still have a high viral load, more than 1,000 copies per ml. So we want to know the proportion as well as the patterns of acquired drug resistance. But we also like to know, to characterize these proportions and patterns by demographic and the clinical characteristics, as well as to estimate the proportion of acquired drug resistance among individuals who are failing second-line based treatment. And we would also like to know the risk factors, okay, for acquisition of drug resistance among individuals who are on treatment. So, CADRI being a cyclical survey, it means this is a repeated cross-sectional study, and it is repeated each year to monitor the trend of HIV drug resistance over time. And in Tanzania, it is implemented in 9 HIV viral testing labs. And these labs are zonal and regional laboratories. 7 of them are in Tanzania mainland and 2 are in Zanzibar. So each year we aimed to collect 1,200 remnant viral load samples, 400 of them from children and 800 from adults. So when we say remnant, it means these are samples that are left over, that are remaining after viral testing has been conducted. So the patient, so we asked for a waiver, okay, of informed consent. So the patient comes on routine basis, submits the sample is tested, the patient receives his or her results. But if the sample is found to have more than 1,000 copies per ml, together with other characteristics, it becomes eligible for CADRI. So normally we included individuals whose samples had more than 1,000 copies per ml, have been on DTG, okay, on dolutegravir-based regimen for at least 9 months, and the volume of the remnant information available on the HIV, on the National HIV database. So once we check that we have the CTC IDs available, age and sex, ART regimen, ART initiation date, date of viral specimen collection, and also date of HIV testing facilities. So these information are important because apart from for analysis, so what do we find from the first round of surveillance? Okay, because people are interested now in knowing how is the DTG-based regimen performing. Okay. So in the first round of surveillance, we collected 1,403 leftover viral samples. And out of these, after checking eligibility status, that we have high viral load on DTG for more than 9 months, enough sample volume, and available information on National HIV database. 1,307 samples were eligible for HIV drug resistance testing. And all of these arrived at the HIV drug resistance testing laboratory, at the Make Specialized Laboratory, and we were able to extract viral RNA from 96% of them. And of the eligible samples, 87% were successfully amplified, and 83% were successfully sequenced. So during the first round of surveillance, PRRT amplification rate, so the PRRT, this is the protease and reverse transcription region. So the virus, okay, the genome of the virus, okay, is divided with 3 transcriptase and the integrase. So when I say PRRT, I refer to protease and reverse transcriptase, and when I refer to iron, I refer to integrase. So of the 1,307 samples, 388 were children samples, and from them we successfully, while 919 of these, one of the overall sequence samples came from adults, and among the adult samples we obtained the 766 sequence. So overall, in this study, we were able to analyze the unsuppressed children who were eligible for, who were among the unsuppressed children from whom we collected the samples for HIV drug resistance testing. More than half were males, and the majority were between resistance to integrase strain transfer inhibitors. So when we say integrase transfer inhibitor, in this group there are around 5 drugs. So overall resistance was 8.6%. So, but the resistance to DTG was 8.3. Well, this is the only integrase inhibitor that we are currently using in the country. Resistance to non-nucleotide reverse transcriptase are the patterns at which mutations occur and cause resistance to ARVs. So among mutations which cause resistance to dolutegravir, the commonest ones that were detected in our populations are the mutations which occur at position 138, 118, and 263. Whereas among mutations which cause resistance to NNRTI, the most common one was the mutation that occurred at position 103. We also detected a high proportion of the kids had mutations against the lamivudine and the emtricitabine, but we found very low levels of tenofovir-associated mutation. So for adults, resistance against DTG was a steep performance in Tanzania. Okay, thank you.
Thanks very much, Dr. Frank, for that presentation. Please, can you give another round of applause to Frank? Okay, thank you. So as we are moving forward to our next presenter, we have who's going to talk us about readiness and laboratories to support HIV drug resistance surveillance in Tanzania, institute we did in Tanzania. So for that, I'm going to welcome Mr. David Stemba, who is our senior laboratory manager at MDH. He holds a Master of Science in Applied Microbiology and also in Molecular Biology and Biotechnology, HIV, TB, and clinical research, while he also including care and treatment programs. And he's specialized when it comes to diagnostic, the quality assurance, and health system strengthening. So on board, I would like to welcome Mr. David Temba for the presentation. Karibu. Please, a round of while he's coming. Yes.
And as well as laboratory outcomes, challenges, and the lessons that we have learned. And lastly, the readiness assessment for the labs that we have in the country to support HIV drug resistance surveillance. So Tanzania has adopted the WHO Africa Regional Action Plan, whose strategy aims to prevent and respond to emergence and the transmission of drug resistance. So the lab surveillance is a core component of these strategies that provide real-time evidence to guide the treatment policy, patient management, program quality, drug resistance patterns before they become widespread. So, as explained by Dr. Msafiri, CADRE leverages routine viral load infrastructure that involve use of remnant viral load specimen to screen for resistance-associated mutations and estimate percentage and pattern of acquired HIV drug resistance among individuals who are not virally suppressed. So the importance of using existing viral infrastructure makes the surveillance cost-effective, quicker, easily scalable, and integration with the routine services. This is because it uses a routinely collected viral specimen, avoiding extra cost of recruiting participants and drawing additional specimen. So we had 9 labs that participated in the CADRE for identification and collection of CADRE eligible specimen. And these labs provide balanced geographical representation across Tanzania regions. So you can see in the map, those regions flooded with green color. These are the regions with the capacity to do viral load testing. So you can see almost the whole country has capacity of performing molecular diagnosis of viral load in the others. And those with red dots are the ones that have capacity to do HIV drug resistance. So, as we have said, the CADRE objective is to estimate the percentage and the patterns of acquired HIV drug resistance among people who are not virally suppressed. So the process flow for the CADRE started at the HIV viral load laboratories, whereby remnant samples are identified, specifically for those that had high viral load. And after identifying or collecting, identify high viral specimen with enough remnant volume of at least equal above 0.5 mils, the next step is to ensure completely availability of client demographic, clinical, and specimen information. Thereafter, specimen are temporarily stored at the same lab where it has been identified, prepared to be transported to the HIV drug resistance, whereby in this project, Temeke specialized labs at the Temeke Referral Hospital here in Dar es Salaam was the center laboratory that did HIV drug resistance. At the HIV drug resistance lab, the specimen were received and processed in terms of amplification and the sequencing the HIV-1 genome for the region of integrase and the protease and the reverse transcriptase using Senga sequencing platform. So quality management system was key in the whole processes to ensure that the integrity of the specimen are well preserved, reagents that are used for viral load and HIV drug resistance are of high quality, and during specimen transportation also maintenance or adherence to cold chain standard is adhered to ensure that integrity of specimen is also good. And at the end of the lab processes, we did analysis and the dissemination of the findings as presented by the previous speaker, Dr. Frank. So the outcomes that we have observed in the lab, at the HIV-DR lab, around 1,256 samples were collected and transported to the Temeke lab for genotyping, whereby 71% were able to be amplified in the protease and reverse transcriptase regions, and 86% of them, of the sample, were able to be amplified in the region of integrase. So during genotyping or sequencing, of the amplified PRRT regions, 93% of the specimen were successfully sequenced, and likewise 96% of the amplified specimen were successfully sequenced in integrase inhibitor regions. So the laboratory conducted quality control for all the sequences that were generated using the WHO recommended tools, the recall software, and as well as WHO QC tools to ensure that the sequences that are generated are of high quality during the data analysis. So the labs, together with the experts from the CDC, Tanzania, and Atlanta, used to review the sequences, the quality of the sequences, and ensure that all the sequence issues were corrected prior to be submitted for Stanford for analysis. So in terms of the challenges and the lessons learned, we have encountered inconsistent supply of viral reagents during the course of data collection. So in those, almost in 80% of the labs that were participated in the cadre had some point stopped the identification due to stock out of viral reagents. So, but we mitigated the challenge by make sure that we redistribute reagents from other labs that had adequate reagents to the labs that have run out of reagents. And of course, to some point, we rerouted or referred specimen from the cadre labs that had out of stock to other cadre labs that had enough reagents to continue with identifications. So from this challenge, we came to learn that it is critical to consider buffer stock at the time we are conducting data collection for surveillance purpose. Also, we anticipated to have a very good amplification rate, specifically for the protease and the reverse transcriptase regions, but we suffered a little bit as we were only able to identify 71%. We were only able to amplify 71% of all the samples on PRRT regions. So we had to address the issue. First of all, we needed to do troubleshooting, identify what could be the root cause. So in this, we did interlaboratory comparison by employing National Public Health Lab. Also, we engaged other collaborators, stakeholders, including the manufacturer and the other experts on the HIV-DR processing. So we came to also notice that during reagent transportation from the supplier down to the country, at some point we could not be able to monitor a cold chain effectively. So the lessons that we have learned here, it is very much key that to engage stakeholders adequately, as well as ensure that we comply or maintain cold chain mechanism during transportation of reagents. Also, during the analysis of the sequence, we were able to observe a number of sequences were inappropriately analyzed, and there were some challenges or issues in number of sequences, and due to some capacity limitation, the lab personnel that were involved in analysis of this sequence could not be able to fix or correct the sequences. So with the assistance from the expert from CDC, we were able to capacity or to train the lab on how to do quality control for all the sequences that were generated and ensure that the sequences were all of high quality, ready for the analysis and data dissemination. So what we can conclude in terms of readiness of our laboratories, so overall in the country we have around 27 laboratories with molecular capacity to do viral load and others in 19 regions. So very few, I think around 85% of all the regions have this capacity. And in the country, we have 5 labs with adequate capacity to do HIV drug resistance, sample transportation system, network. We have very adequately with the ability to adhere to cold chain during sample transportation. Also, all the labs have adequately capacity to store the specimen in the required cold chain temperature. The personnel who are working in these labs, they are well trained and capable. So what is needed to be assured to conduct HIV-DR lab-based surveillance is funding support. So the lessons from this project is, number one, maintaining cold chain adherence is very crucial. That ensures specimen integrity and as well as quality of reagents for reliable testing results. We also needed to make sure that we keep buffer stock for both the viral load and HIV-DR to ensure identification of eligible sample and the processing of the HIV-DR is smooth from the day one where data collection is started to the last day of sample processing. Also, stakeholders' engagement is very key. As I have pointed out, that we had a challenge of PRRT amplification, but through engagement of other stakeholders and other experts, we were able to identify the root cause, one being improper maintenance of the cold chain, other being that during the processing or lab reaction, the reagent required to be handled or subjected to icing condition to ensure that to optimize the processing of the to optimize the processing of amplification of these regions. Also, it is very crucial to conduct sequence analysis to ensure the sequence that are generated or submitted for data analysis, they are of high quality. And we conclude that cadre is very feasible and scalable, as it is very cost-effective, user-friendly, that require minimal additional resources for it to be able to run. Thank you all for listening.
Thank you very much, Mr. Temba, for please the next round of applause again. Thank you. So let's move on to our next presenter. This is more of the, when it comes to clinical perspectives. For this, I was to welcome I can say it's my professor, who has trained me when it comes to HIV. So this no other is Professor Samuel Kaluvia, who is an associate professor of internal medicine at KUHAS. He's an endocrinologist and HIV specialist, and he leads endocrinology, diabetes, and HIV unit at Buganda Hospital. and he chairs Tanzania National HIV Clinical Subcommittee, CTLC. And his research has been focusing on HIV, AIDS, diabetes, and the comorbidities. So I'm very happy and very proud to welcome Professor on board. Welcome, Professor, for presentation.
Good afternoon, everyone. My name is Sam Kaluvia from Kuhas, Bugando. So I'm going to give an overview of findings from the Tanzania genotypic antiretroviral resistance testing for 2024. So HIV drug resistance testing practice in Tanzania, it is routinely done for recipients of care failing second-line regimen only in this country. Recipients of care failing first-line regimens are empirically switched to second-line IRT, non-HIV drug resistance testing, because we don't have individualized treatment. So we have fixed first-line and second-line treatment. So gut results and gut history guide ART management decision for people living with HIV after gut. And of course, biochemical results. If they have chronic kidney disease, we cannot give some of the drugs like tenofovir diproxyfumarate. And then we switch to third line and recycle previous used regimens, meaning recycle previous used ARVs like AZT and tenofovir, if they are still viable, they are still viable. So although ROCs still have drug resistance after failing first-line treatment, but in most cases we find that even if we do drug resistance testing in first line, it is not going to change the regimens in second line and the outcomes, because with the current first line regimen, tenofovir, lamivudine, DTG, there's no cross-resistance to second line regimens. Tenofovir, the K65R, does not impact negatively on AZT. So that's why we stopped using the stavudine and AZT, because they would impact on tenofovir resistance efficacy. So that's why tenofovir preserves AZT in second line. Okay? And lamivudine resistance even increases susceptibility of AZT or the virus to AZT. So it's a good mutation. So that's why we recycle lamivudine in second line, even third line regimens, because it makes the virus less fit to replicate, less fit to be transmitted, and increases susceptibility of the virus to AZT and tenofovir. So adults failing second regimen, they are defined as having failure if the viral load is more than 1,000 copies per minute after enhanced adherence counseling of 3 months. This is debatable because HIV is the only disease which we don't have universal definition of failure. If you go to the US, the viral load more than 200 copies per minute is regarded as virological failure. In Europe, more than 50 copies per minute. So we are saying it should not matter whether the patient is from Manhattan, Mwanarumango, or Mnazi Mmoja. We should have a universal definition of virological failure. Why? Because initially we thought that the virological window from 50 to 999 was harmless. It's not so. It is associated with increased risk of drug resistance, increased risk of treatment failure, increased risk of cardiovascular diseases, and increased risk of mortality. So it is no longer, we should no longer take it as a harmless window. And that's why it is called low-level viremia. Low-level viremia, we should not be doing nothing. We should be actively doing something to prevent these side effects. One of the things which Temba said is we don't have the capacity to do drug resistance for low-level viremia below 400 copies. Now that's not, we should be able to do that. One of the reasons why the viral load for virological failure for resource-limited setting is 1,000 is because the machines which we have now cannot determine drug resistance if the viral load is below 1,000 copies per mil. And the virological failure has been a moving target with WHO. They started with 10,000. They were challenged. They went to 5,000. Now, 1,000. But even 1,000 is not good enough. Because we tell someone with a viral load of 500 here, you're doing very well. They go to America and say, where have you been? Why are you so late? So we should be now thinking about being able to do drug-resistant testing even in the level of low-level viremia. In the US, they can do viral load testing if the viral load is above 200 copies. So machines we are using should follow the science. So this is the algorithm for HIV drug resistance testing. I'm not going to dwell on that. And the samples processed in Tanzania between 2021 to 2025 were 1,795. Now, according to research in sub-Saharan Africa, failure of second-line treatment ranges between 20 to 40%. In Tanzania, there was a large study which showed that failure is about 30%. So what we are actually seeing now is the tip of the iceberg. Maybe in Africa we could say the nose of the hippo. Just a very small fraction. And that has got very serious clinical implications. Transmission of drug resistance in the communities. Now, what did we find? Protease inhibitor region resistance 20% for these years. Reverse transcriptase, that is RT, was 55%, and integrase strand transfer inhibitors was 23%. Now, the previous studies, the previous rates which we heard from the previous presentation were acquired drug resistance, not among those who were failing regimen. So that's why they're much lower than these. In nucleoside reverse transcriptase inhibitors, the major resistance-associated mutations were 87. TAMs and nucleoside RAMs were 78, which is 89.6%. And this is because these patients have been, these recipients of care have been on AZT-based regimens. Now, one interesting thing which we found was of the 78 TAMs, 20%, that is 25%, that is 1 in 4 TAMs, were due to tenofovir-based regimens. Now, this is not quite what we expect, because tenofovir is not usually associated with TAMS. So what could that mean? It could be some of the recipients of care did not disclose as a T use when they went to another clinic. So that's what could explain that. That's why. It's very unlikely that it could be due to transmitted drug resistance, because transmitted drug resistance of nucleoside reverse transcriptase inhibitors is very rare. It is only common for non-nucleoside reverse transcriptase inhibitors. M104 frequency was quite high at 1%. That is due to lamivudine or emtricitabine. And K65 are developed in very few cases, 4.6%, which is almost close to what they found in, which was 5%. Now, we normally in third line will recycle nucleoside reverse transcriptase inhibitors. So AZT was susceptible only in 37% of cases, which means we could only recycle AZT in third line in that percentage, 37%. Tenofovir was susceptible in 53%, which is good. We could recycle it in 53% of cases. And we can even recycle tenofovir in second line. And this is the current WHO recommendation, because it's very rare. Resistance to tenofovir is very rare. It is because the K65R is uncommon, and when we have resistance due to tenofovir, it is mostly due to effect of TAMS. Now, as expected, non-nucleoside reverse transcriptase inhibitor was quite high, 93% of those exposed to NRTI. This is because these drugs have got a very low genetic barrier to resistance, and therefore they do not forgive non-adherence. And that's why WHO recommends now we should stop using these drugs and pivot to integrase transfer inhibitors, which has got a very high genetic barrier to resistance, and they can forgive non-adherence. PA resistance was also very uncommon. It was found in only 3 out of 5 recipients of care. Cross resistance to darunavir was very low, only in 5%, which means we can use darunavir in third-line regimens very comfortably, which is a second-generation PI. Now, very concerning was resistance to integrase transfer inhibitors of more than 40%. And in most of the cases of integrase transfer inhibitors, there was pan-INST resistance. That is, all the INST were resistant. And this could be due to irrational sequencing, maintaining the backbone, and only adding one drug to a subsequent therapy. So it's concerning because DTG is one of the most effective weapons. Now, when it comes to second-generation NRTIs, etravirine can be used in third-line treatment because resistance to etravirine was low. Azathioprine can be recycled in majority, in about 1/3 of cases. Now, what are the clinical implications? In about 20% of cases of failure of TDF-based regimens, TAMS impacting negatively on efficacy of AZT was develops. Darunavir can be used in third-line ART in 95% of cases, even with previous history of PI use, lopinavir and trazanavir. Sequential DTG monotherapy should be avoided to preserve its efficacy. When we are transitioned from TLE to TLD, some of the cases had virological failure. So when they transitioned from TLE to TLD, that was sequential monotherapy because there was resistance to tenofovir and resistance to lamivudine. So they just added one drug, and that's why it's very easy to fail. So what are the challenges? Irrational ARV sequencing, retaining the backbone of a failing regimen and adding one anchor ARV is a problem. Leaving recipient of care on prolonged exposure to a failing regimen. Very extended ESC, delayed diagnosis of virological failure, and delayed switching. All these led to multi-class, including 4-class HIV drug resistance. So in limited third-line ARV, it limits third-line ARV options due to multi-class HIV drug resistance. And in our settings, because we have only 4 classes, if we have resisted to all the 4 classes, that is akin to pan-HIV drug resistance. So the way forward, we need to prevent cross-resistance and preserve options in subsequent ART regimens. We need to lower, in low-level health systems, we need to support ART failure case finding for second-line treatment failure, because we are seeing just a very small fraction, and any referral to gut and timely gut results review. Virological failure after 3 months of ESC completion and a repeat of HIV viral load, continue with ARC when there are no HIV drug resistance, and switching only with there is drug resistance. And we need to expand our formulary, ARV formulary, for managing multi-class HIV drug resistance, because we are very much limited. Whereas in Western countries, they have 9 classes, we have only 4 classes. So our options are very much limited. So we need to think about introducing other classes. Thank you very much.
Thank you, Professor Karuvia, for that presentation. And please, can you give a round of applause again? Thank you. As we are coming to end of our presentation, but last but not least, we still have one more presentation. We think it will take us quickly just on the transmitted part of it, which is the risk factor for HIV transmission. So with that, I would like to welcome Dr. Gulak, who is the director. Next slide. Okay, let me introduce is Dr. Gulak Liatu, who is our director, IT. Okay, so we have the director of program at MDH. He's the medical doctor and he holds PhD in global health. He's a public health specialist leading large-scale HIV/TB and reproductive maternal and child and adolescent health programs. He had extensive expertise in operational research, implementation science, services integration, and system strengthening health routine. With him today is going to take us about the on the transmitted HIV data, especially in our low and income countries, as part of the prevalence and the risk factors. So maybe on board, let me welcome Dr. Gulak. Karibu Daktari.
Good evening. Yeah, You're right, it is evening. When other presenters came in, they were telling you good afternoon, so we have switched. And as they say, it's tricky and difficult to present before lunch, but it's also tricky and difficult to present before people's Q&A session. So no worries, it is short. I will not keep you from the interesting Q&A session that is going to follow. So as mentioned, the next section is about transmitted HIV drug resistance. You have been hearing throughout from the presenters that went before me, mostly about acquired drug resistance. So we're going to switch gears a little bit and talk about transmitted drug resistance. And as Professor mentioned very well, if we do not control acquired drug resistance, then we run the risk of getting to transmitted drug resistance. So, and this is something that Professor Doreen also mentioned at the beginning. So you can think of HIV drug resistance in two ways, either acquired or pre-treatment. Pre-treatment HIV drug resistance can either occur when it is transmitted at the time of infection among people who have never used antiretroviral treatment, or it can be acquired during previous exposure to antiretroviral agents. And for pre-treatment drug resistance, the populations that are usually involved are either infants exposed through vertical HIV transmission, or as I said, ART-naive individuals that have never used ART, but they get infected with a virus that has strains that have already mutated, or again, individuals with a history of using post-exposure prophylaxis or pre-exposure prophylaxis. So transmitted drug resistance is a specific type of pre-treatment drug resistance, which is also known as primary drug resistance. It's different from what we've been hearing in earlier presentation, as I said, and it's different from what we has already been presented very well with regard to cadre and GATT, which is acquired. This is when an individual gets infected with a virus that is already resistant to antiretroviral drugs. And data on transmitted HIV drug resistance is very limited, particularly this part of the world in low and middle income countries. So most of what I'm going to share is reviews and meta-analysis from studies that majority have been published in developed countries and very limited in low and middle income countries. So what is the prevalence of transmitted drug resistance? So there's this very nice meta-analysis of studies that has been published. The meta-analysis was published in 2021, but it included studies that were published from 2008 to 2021. It covered 12 original research studies that had looked at transmitted drug resistance, one cross-sectional survey and 11 cohort studies. And it represented a little bit over 3,500 participants, with the smallest study having about 43 participants, and then the largest study having a little bit over 1,000 participants, majority of them having more than 100 participants. And these were ART-naive participants that were coming from either voluntary counseling and testing, blood donation centers, and other places. So from this study, we're seeing the prevalence of transmitted drug resistance was as high as 9.3 to any antiretroviral agents, and highest among non-nucleoside reverse transcriptase inhibitors at 5.7, and then the NRTIs and PIs were around 3.4 and 3.3, and it was very low among the integrase strand inhibitors, which is the first-line treatment that we use here in Tanzania. So digging a little deeper, so from this meta-analysis, looking at NRTIs again, so the pooled prevalence, as I said, was 3.4, and this was coming from about 10 studies with over 3,000 participants. And then the most common mutations that were reported across these studies were T215C, D, E, F, I, as well as M41L. And then for the non-nucleoside reverse transcriptase inhibitors, which had the highest prevalence, you'd remember from the previous slide, of 5.7, this was reported in 11 studies. And as we've heard, this group has low genetic barrier to resistance, hence the higher prevalence of transmitted resistance. So this was reported from 11 studies covering over, again, 3,000 patients. And then the most common mutations was K103N, S, and Y, 181C, I, and V. And then the PI, the pooled prevalence of transmitted resistance to PI was 3.3%. And then this was reported in 10 studies, again involving over 3,000 patients, and the most common mutations were as seen on the slide. And then the last one was the pooled prevalence to INSTI resistance. This was the lowest, 0.3%, and mostly it was coming from one study. Two of the 3 studies that were involved in this did not find any resistance, so it was mostly coming from one study, but again, the pooled prevalence was 0.3%. Yeah, so looking at factors associated with transmitted drug resistance, again, literature remains scarce in this area. However, there are 2 studies that had looked at this. One was a study in China that had looked at around 1,300 participants who were newly diagnosed with HIV. And then from this study, what they found to be associated with the risk of having transmitted resistance was unmarried status, education level of either junior high school or below, as well as this particular subtype of the virus. So again, some of these risk factors are somewhat related to the risk factors for acquiring HIV in the first place, because the risks that predispose you to acquire HIV may also predispose you to acquire resistant strains of the HIV. And then there was another study that was done in Cameroon. This had looked specifically at pre-treatment drug resistance among about close to 400 patients. And then this did not find any significant associations with sex, age, WHO stage, or HIV genetic diversity. However, people that were residing in urban settings were found to be more likely to be diagnosed with pre-treatment drug resistance. So in conclusions, what we find from what is available in literature is there is moderate level of transmitted HIV drug resistance based on the WHO classification, and luckily very low transmission for INSTI, so very low transmitted INSTI resistance. But then factors that may be associated with pretreatment or transmitted drug resistance may include unmarried status, low level of education, and then urban residence. So then I leave you with a question: how can we use the current HIV drug resistance surveillance to understand, try and think through pre-treatment or transmitted drug resistance? Yeah, thank you for listening.
Thanks, Dr. Goodluck, and thanks all presenters for their presentations. So I think due to time, we have very short time, limited time to the next session. So with that, maybe I'll just welcome the presenters. If there's only 1 or 2 burning questions for the presenters so that we can wrap off today's. Please, all the presenters would be welcome to the podium. So can you have, if any, 1 round of questions? So, yes. So, yeah, so, okay, we are going to have 1 question.
Thank you so much. I would like to take this opportunity to congratulate the panelists for very good presentation. I just want to make one comment and one question. So, looking at where we came from when it comes to HIV drug resistance testing, I think the country have made tremendous progress. The investment from donor and development partners such as CDC have helped to create substantial capacity for HIV-DR. As we speak today, as we're here today, there are 5 laboratories around the country that can conduct HIV-DR. You have the National Lab, you have Temeke, you have Dodoma, you have Mbeya, and Bugando. And the machines installed in this laboratory not only can do HIV-DR in the cutoff of 1,000 per mil, but even low-level viremia. It's just a matter of validation, but these machines can do that. But also, I think the capacity now extend even to the next generation sequencing that can do even deeper low-level viremia. So in terms of capacity, I think the country is in a good place. I think the question now is looking forward, especially in the donor environment where the donor are not in the picture. How are we going to sustain these gains in HIV drug resistance capacity and probably even improve upon it? Thank you.
Okay, thank you. So with that question, due to time, we may not be able to continue. So for those who have got questions, please, we have our presenters will be around, so you can approach for the questions due to the coming session, which will take your call now. For that, I would like to thank all the presenters and apologies for the time, which has been a very short time on our side. And yeah, thank you. Thank you very much.
Hello, the next session is CEO Around the Table. This is exclusive for invitation. So if you have an invitation, you can stay in the room. If not, the other session is in Mikumi, who is who session. So karibuni sana.